you everybody for being here today. It is my great pleasure to be able to introduce Nadia Nabulsi, who is going to present some work that she's been working on with one of the pharmacists here and with Dr. Lee as well. I know that Nadia has a background in public health as well, and she's a very hard worker, and she is a pleasure to work with. This project is one that's not necessarily her primary area of interest, but one where she's worked a lot on the analysis, and that's been a big thing that she's really enjoyed. So she'll have fun talking to you about that part in particular. So without further ado, help me welcome her.
Hi, thank you. Thank you for the introduction. Thanks everyone for coming, and thank you to everyone who dressed up today for the ISPOR Halloween celebration. So my name is Nadia Nabulsi. I am presenting on baseline predictors of antiviral therapy failure among chronic hepatitis C patients at 4 U.S. institutions. The name of my presentation is not quote unquote, as some of you might have seen in last week's Pulse of PSOP email, but I thought that was pretty funny. All right. I would like to especially thank Dr. Michelle Martin, Dr. Lisa Sharp, and Dr. Todd Lee for all of their mentorship throughout this ongoing project. Dr. Martin is a clinical pharmacist here at UIC who specializes in hepatitis C. I had the fortune of being introduced to her this past summer, and the work I'm presenting today is actually a secondary analysis of the data that was collected for the original study that I was involved in over the summer. I also want to disclose that the original study was funded by Gilead. Okay, so I'll start with some background about hepatitis C. It's a liver infection caused by the hepatitis C virus, and I'll refer to it from now on as HCV. It's often described as acute, meaning it's a new infection, or chronic, meaning a lifelong infection. If untreated, it can lead to liver damage, scarring of the liver, so cirrhosis or fibrosis, liver cancer, and death. And there were about 18,000 deaths related to HCV reported by the CDC in 2016, but this is believed to be an underestimate. Most recently, the CDC reports about 3.5 million cases of HCV in the U.S. HCV is spread through the blood. Today it's typically spread through sharing needles, and the majority of cases in the U.S. are due to drug use. Before 1992, HCV was typically spread through blood transfusions and organ transplants before we had better testing of blood donors available. People at increased risk of HCV are shown here. I'm not going to read through all of them, but I do want to emphasize that there's a lot of stigma around HCV because it's typically associated with intravenous drug use. Drug users, though, aren't the only people who can get infected. Most people who are infected with HCV do not experience any symptoms. There's 3 out of 4 people who have it that don't even realize they have it. And the most common symptom is fatigue, which can easily be mistaken for some other more mild condition, something as simple as a cold. And also I want to point out that people can be reinfected with HCV after they're cured. I'll be referring to SVR throughout the rest of the presentation, so I want to make sure it's clearly defined. At 12 weeks after the patient has completed HCV treatment, a blood test is used to look for hepatitis C virus in the blood. The amount of virus in the blood is referred to as viral load. And when the test results indicate that the viral load is not detected, then the patient is said to have achieved sustained virologic response, or SVR. And SVR is clinically defined as a cure. Current Hep C treatments are made up of combinations of drugs called direct-acting antivirals, or DAAs. Recently, treatments have become much more effective and well-tolerated, and they have few side effects. The SVR rate is generally around 90% today, and treatment typically consists of just 8 to 12 weeks of oral therapy. The figure on the right here is showing how the effectiveness of HCV treatment has changed over time. You can see that the first drugs in green from the early 90s only cured about 10 to 30%. From 1998 as recent as 2013, cure rates from the new drugs at the time were around 50 to 80%. And then there's a jump to the cure rate from today's drugs, which is shown here around 95%. The text here might be a little bit small, but I just want to point out a couple of things. So even though today's HCV treatments are very effective, getting treatment costs covered by insurance can be a significant challenge. One study shown here at the top reported an overall insurance denial rate of 35.5% between 2016 and 2017. The denial rate was broken down into 35% for Medicaid-insured patients, 15% for Medicare, and 52% for commercial insured patients. Also, in many states, Medicaid will only cover patients that are cirrhotic, meaning patients must have progressed to severe liver damage before their insurance covers their HCV treatment. Some states don't provide Medicaid coverage to patients with a history of alcohol or substance use, and some states only allow certain specialists to prescribe treatment, which can be difficult to find. These restrictions are all significant barriers to providing patients with a cure that already exists. This slide just highlights the average cost of treatment for the combination DAAs that are currently available. You can see how expensive these treatments can be, ranging from $26,400 for an 8-week supply of Mavorite to $94,800 for a 12-week supply of Harvoni. Because HCV is the leading cause of advanced liver disease worldwide, it has an enormous economic burden. In more recent studies, the total direct economic burden of HCV-related liver disease in the United States was estimated to be $7 billion annually. And there's also indirect and public health burdens. There's a higher unemployment rate among HCV patients. There's lower wages and impairment in work productivity. And from a public health perspective, since there's no vaccine, there's continued transmission. And there are screening efforts, but in order for these to be impactful, you have to have successful treatment. Universal access to highly effective these curing medications would decrease the burden of HCV, if not eliminate the disease completely, but it also requires really large investments that are currently unaffordable in most of the world. So therefore, there's a focus now on developing cost-effective strategies with the aim to get the most benefit for the least expenditure. So again, I was introduced to this space through a research study I was involved in throughout this past summer with Dr. Todd Lee and Dr. Michelle Martin in the UIC College of Pharmacy. And there were other investigators from other US sites as well, which I'll show. The original study aimed at determining SVR rates of clinical pharmacist-driven HCV treatment models, and I'll briefly present some background for this study and the primary result before going to the focus of this presentation, which was a secondary analysis of the data that was collected. So the data source for these analyses, the original and mine, was an electronic medical records for 1,358 patients who initiated HCV treatment under the care of a clinical pharmacist at 4 different U.S. institutions. UIC was one of the sites, specifically our hepatology specialty clinic, and we contributed 862 patients to this study. Vanderbilt's outpatient infectious disease clinic in Nashville contributed 296 patients. Temple University's infectious disease clinic and internal medicine clinic in Philadelphia had 146 patients, and finally Creighton University in Omaha contributed 54 patients from its outpatient primary care clinic. The sites did have some differences in patient characteristics, and I'll talk about that more in the methods. This is generally the treatment model that the 4 sites utilized and highlights the steps at which the pharmacist is involved with the interdisciplinary healthcare team. The steps involve an initial referral for HCV treatment, which includes a patient assessment and a drug-drug interaction assessment, and then this is followed by assistance with access to medication, since, as we've seen, this can often be a difficult step. Once the patient is able to obtain their medication, then the pharmacist assists with treatment initiation through patient counseling, and they order labs and follow-up visits. Throughout treatment, the pharmacist is involved in on-treatment monitoring of adherence, adverse drug reactions, and lab results. And then the patient receives post-treatment care from the prescriber, and they have their SVR assessed. So for inclusion from the initial sample of 1,358 patients, patients had to have initiated dual or triple combination DAA treatment between January 1st, 2014, so when the newer medications were available, and March 12, 2018, under clinical pharmacist care. Patients were excluded if they had not yet reached 12 weeks post-treatment completion by September 7th of this year, because that's when we ran the primary analyses. And these patients were excluded because they did not have the opportunity to have their SVR labs drawn 12 weeks after treatment completion, so they could not be classified as treatment successes or failures. And this figure at the bottom shows the treatment timeline. So patients initiate either 24, 16, 12, or 8 weeks of therapy from these different starting points. And treatment initiation is measured from the date medications actually obtained and started, not the date it's prescribed. Then patients complete treatment here, and 12 weeks later they have their lab testing done to determine if they achieved SVR. This figure shows patient attrition throughout the treatment process. After applying the inclusion and exclusion criteria, we started with 1,253 patients. And we used an intent to treat analysis with a dichotomous outcome. So patients were either classified as a treatment success or a treatment failure, meaning they did not achieve a measured SVR. After initiating treatment, 24 patients discontinued treatment, 22 were lost to follow-up before treatment completion. So we had 1,207 patients who completed treatment. Of these, 73 patients were lost to follow-up after treatment completion. So we had 1,134 patients who had SVR data available. And then of these, 1,079 achieved SVR and 55 did not achieve SVR. So everything in a red box here is considered a treatment failure, while the green box is a treatment success. One of the primary outcomes of the original study was the overall SVR rate, which was 86.1%. So that means 86% of the 1,253 patients who entered the study achieved SVR. So I was interested in taking these findings a step further and trying to assess if there was a way to use the data that had been collected to predict what patients were at risk for not achieving measured SVR. You can see from this treatment cascade that there is generally a significant gap between patients that are prescribed HCV treatment and those that achieve SVR. There are several barriers to HCV elimination, which is shown by this figure, but I was particularly interested in this last drop. If there were a way to predict which patients will not achieve a measured SVR when they are initially referred for HCV treatment and assessed, there may be a way to reduce that gap. This is a conceptual framework to describe how patient characteristics and the structure of the healthcare system can influence the process of care that patients go through and the aspects of care that they are able to benefit from. And then this then affects whether or not patients achieve a measurable SVR, discontinue treatment, or are lost to follow-up. If patients do not achieve a measurable SVR, this can lead to negative long-term patient and public health outcomes. For this prediction study, we are interested in patient characteristics, particularly the demographic and clinical characteristics that we had available from the original data set. We want to determine if there are patient characteristics that predict treatment outcomes and help prevent negative long-term and public health outcomes. So the research question we're trying to answer, summed up, is what are baseline predictors of treatment failure in HCV patients that initiated treatment at 4 U.S. institutions with a clinical pharmacist-driven treatment model within a multidisciplinary team? Again, the model I'm presenting focuses on characteristics at baseline. So I was trying to develop a predictive model for patients at the initial referral and patient assessment phase that we saw earlier. Therefore, the analysis does not include anything about the course of treatment, the regimen, or adherence. Other publications have recognized this as an important topic of study and have attempted to answer this question. However, these studies looked at older interferon treatment options that don't apply today, or they used less thorough methods utilizing just chi-square analyses or logistic regression on its own. So identifying predictors of treatment failure is important because it can provide an early warning sign of high-risk patients, and it can alert clinicians as to whether they should do something different in that patient population. This could ultimately provide a tool to guide additional treatment monitoring strategies, personalized interventions, and strategic allocation of resources so that we can more closely follow up with at-risk patients and avoid treatment failures. As we already saw, treatments are very expensive, so we might just be wasting money if they don't achieve their potential that they're capable of. Identification of predictors for treatment failure could help decrease healthcare costs for patients in the healthcare system. And the aim of this study aligns with this movement towards personalized HCV treatment and efforts to find suitable predictors of response for a given patient. This also comes back to the current strategy of trying to get the most benefit for the least expenditure. Before we get too much into the methods, I want to point out that I did all of the analyses in stats. And the first step in the methods involved discussions with the clinical pharmacists that were involved to identify baseline candidate predictor variables from our data set that we hypothesized might be linked to treatment failure. So for the first variable elimination phase, so we're going through and trying to eliminate the variables we want to include in the models. So for the first phase, we removed variables that had collinearity or variables that had a prevalence in less than 3% of the sample. Post-transplant immunosuppression agents was collinear with post-transplant, which makes sense because they're on immunosuppression agents. And we kept post-transplant since it seemed to be slightly more accurately recorded in the data. Dialysis was seen in only 2.7% of the sample, so it was removed to avoid small cell sizes. Then we found that there was statistical evidence that the patient populations at the 4 sites are different. The sites were significantly different by all of our candidate predictors that we have so far. Conceptually, we also know that these 4 sites have different types of clinics and providers, so there may be unmeasured differences that we need to try to account for. So we decided clustering would be important in this analysis. In logistic regression, observations are assumed to be independent, as we know, but with clustered data, responses may be correlated. This seems to be the case with our data in which the observations are clustered by site. Therefore, ordinary logistic regression would not have been suitable because it would have biased the standard errors. And when we adjust for clustering, beta coefficients are not affected, but the standard errors and the p-values are, so ignoring clustering could lead to errors in determining which variables to include in the model later on. This table shows evidence of the impact of clustering. So I ran the model in the original data set with the 1,253 observations with the 18 variables that we've decided to include so far to see how clustering affects the variables in the model. I didn't include all of the 18 variables here just for simplicity, but here are just a few of them with their chi-square test p-values shown in the table, indicating whether or not the variable significantly improves model fit. And you can see that clustering causes the significance of some variables to change at an alpha level of 0.05. Before we could do any modeling or chi-square tests to compare the treatment successes to failures, we needed to split the original data set into a derivation set and a validation set, so 2/3 and 1/3, so that we could eventually build our model in one set and then test it or validate it in another. When I split the sample, I stratified on SVR, or treatment failure rate, to maintain the approximate proportion that was in the original data set. So then in the derivation set, I did bivariate analyses, chi-square tests to look for associations between each candidate variable and the outcome of treatment success versus failure. The variables that were significantly associated with the outcome at a significance level of 0.25 were selected for possible inclusion in logistic regression prediction models. And we chose this alpha level, even though it's high, as a threshold for including variables in the model because this has been suggested elsewhere as an appropriate threshold for this step. And this table just shows the variables that were significantly associated with the outcome. So insurance, age, treatment history, history of IV drug use, history of alcohol use in the last 6 to 12 months, HIV infected, whether or not the patient's co-infected, whether or not the patient's on opioid replacement agents, if they had drug-drug interactions at baseline, if they have hepatocellular carcinoma, whether or not they're cirrhotic, and whether or not they've received an organ transplant in the past. Okay, so we removed the variables that were not significantly associated with treatment failure with a p-value less than 0.25. Recall that dialysis and post-transplant immunosuppression agents were already eliminated because of collinearity and having a prevalence less than 3% in the sample. So then we're left with the 11 variables that are shown here. Okay, this might be kind of an exaggeration, but this was the fun part. The modeling stage. And before I go into detail, I just want to give an overview of what I'll be talking about on the next several slides. So the model selection method I used is based on drawing repeated bootstrap samples from the derivation data set, which I showed you earlier, the 2/3. Within each bootstrap sample, a stepwise selection was used to develop a parsimonious predictive model. And then I ranked variables by how often they were selected in these bootstrap samples as predictors. Different models were created based on how often the variables were selected, and then each candidate model was assessed for predictive ability and a final model was chosen. So I'll go into each of those steps now in detail. So bootstrapping is a method some of you may be familiar with already that relies on random sampling with replacement from known observations. If we knew the true population distribution, we could use parametric bootstrapping, but an alternative is non-parametric bootstrapping. And this technique allows us to estimate the sampling distribution of almost any statistic using the same sample repeatedly. Since we allow for replacement, the bootstrap samples are not going to be identical. I generated 100 bootstrap samples, and this graph shows the distribution of my treatment failure rate among these samples. And recall that approximately 14% was the average treatment failure rate among the original sample, the derivation set, and the validation set. Based on this histogram and a Shapiro-Wilks test in the QQ plot that I looked at, it appears that the mean treatment failure rate among the bootstrap samples is normally distributed. Bootstrapping was used in this case not to assess the distribution of a test statistic, but to assess how often a specific predictor variable was included in the model. Therefore, we could apply stepwise variable elimination to determine the probability of each variable being included in the model. Automatic variable selection methods are often criticized because they may be likely to wrongly identify noise variables as predictors, but bootstrapping allows us to assess the strength of the evidence that an identified variable is a true predictor. It's likely that all of the variables that we're putting, so all 11, will be selected at least once, but variables that are true predictors of the outcome should be selected in a majority of the bootstrap samples, whereas noise variables would be selected in only a few samples. So then within each bootstrap sample, I use stepwise logistic regression to develop a parsimonious predictive model of treatment failure. Stepwise regression is a combination of forward and backward selection in which variables are considered for addition or subtraction in each step by assessing their impact on model fit. And I put together this diagram to try to show how the variables are selected for final inclusion in the model through this stepwise process. So first, y is regressed on each x, and the program looks for any p-values less than 0.05 for the independent variables, indicating that they significantly improve model fit. The x variable with the lowest p-value is then added to the model. And then the program regresses y on each x in the model and not in the model. If there's a p-value for an x variable that is not currently in the model that is less than 0.05, then it adds it to the model. If not, then the stepwise process is done and you have your final model here. If there is a new x variable added to the model, then the program looks for any p-values for x's in the model that are greater than 0.05. If these are found, then the x variable with the maximum p-value is removed, and then essentially that process is repeated until there are no more variables that are not in the model that have a p-value less than 0.05, and there are no more variables in the model that have a p-value greater than 0.05, and then you have your final model. So this is where I ran into issues with choosing a procedure in SAS. My options I decided were for logistic regression were ProcGenMod, ProcLogistic, or ProcSurveyLogistic. And I figured out that none of the procedures do everything I wanted them to do, unfortunately. But as we saw, clustering was clearly important, so I needed that. So ProcLogistic was not a good option. Automatic model selection was also very important for these methods, but neither ProcGenMod nor ProcSurveyLogistic can do this in SAS. Luckily, I found this macro that runs automatic forward, backward, or stepwise model selection in SAS using ProcSurveyLogistic, so I ended up using this procedure. The only function that was still lacking was automatic generation of ROC curves, but I'll discuss this in a few slides, but this can be done manually, so it wasn't really an issue. Okay, so this figure shows each variable that was entered into the stepwise selection procedure and the number of times it was selected in the final model for each of the 100 bootstrap samples. So for example, age showed up 89% of the time, meaning it was selected in 89 out of the 100 bootstrap models that were created. As you can see, there were no variables that showed up 100% of the time, indicating that there weren't any fully certain predictor variables. I put cutoffs here showing which variables showed up in at least 80% of the models, 50%, and 40% of these models. And these cutoffs will help determine which models to run in the validation set. We'll get there soon. Okay, so before I go into the results of testing the models in the validation set, I want to talk about receiver operating characteristic, or ROC curves. This is the measure of predictive performance that I use, and I'll show you what one looks like on the next slide, but I want to quickly explain how this relates to sensitivity and specificity. So the distribution of the model results will overlap, as shown in the figure on the left. So for every possible cutoff point selected to discriminate between the two outcomes, there will be some cases with the treatment outcome correctly classified, but some with the treatment outcome misclassified. In our case, the decision threshold will correspond to the adjusted predicted probability of treatment failure generated by the logistic regression model. The threshold indicates at which point we classify the patient as a treatment failure or not. So for example, if we use just the mean treatment failure rate of 14% as the cutoff point, then anyone with a predicted probability of failure greater than or equal to 14 would be classified as a treatment failure, while those below 14% would be classified as a treatment success. So we're going to try to find the most accurate threshold. And the small figure on the right is just emphasizing that when you select a lower threshold value, then the proportion of true positives and sensitivity will increase, but the proportion of true negatives and specificity will decrease. So this is what an ROC curve actually looks like. Each point on the ROC curve represents a sensitivity specificity pair corresponding to a particular decision threshold. The area under the ROC curve is a measure of how well a model can distinguish between two diagnostic groups, in this case, treatment success versus treatment failure. Area under the curve ranges from 0.5, which is as good as pure chance, so it's really bad, to 1, which would indicate perfect discrimination. So remember back to the number of times that each variable was selected in the bootstrap models, and again, notice these thresholds of 40%, 50%, and 80%. So based on these frequency cutoffs, 4 separate models were created and tested in the validation set. And I want to emphasize that all of these analyses now were done in the validation set. The first model, Model A, included only significant predictors, which were variables that appeared in at least 80% of the bootstrap model. So these are the first 3 variables at the top. The second model, Model B, included variables that appeared in at least 50% of the bootstrap model. So it includes HIV-infected, opioid replacement agents, in addition to everything that's in Model A. And then the third Model C included variables that appeared in at least 40% of the models, and the fourth Model D included all of the candidate variables. Unfortunately, the predictive performance of each model was poor. In the validation set, the highest area under the ROC curve was only 0.684, which corresponds to Model C, and this gets a grade of poor. Sadly, model fit was also poor in the validation set, as indicated by likelihood ratio tests. So there was still some opportunity for some good news, because we could now compare the ROC curves to see if some models were significantly better than others in their predictive ability. When we compared to the ROC curves of each model to chance, we found that all models were significantly better than chance, except Model A, which is the one that just includes the 3 variables that were in 80% of the bootstrap samples. So this means that every model except Model A is significantly better than chance in their ability to predict or discriminate between treatment success and treatment failure. So that's a good thing. On this slide, I'm using the same methods that were shown on the previous slide to compare ROC curves, but this time I compared all the models to the one with the highest area under the curve, which was Model C. And again, Model C includes variables that appeared in at least 40% of the models, and the area under its ROC curve was 0.684. It turns out that Model C is significantly better than A and B in terms of predictive ability. Model C and D, which had very similar ROC curves, and the areas under the curve were not significantly different. Okay, this is our actual sensitivity and specificity curve for the best model, which was Model C. And again, this is from the validation set. I want to point out that the best probability threshold for this model is 0.144 in terms of maximizing sensitivity and specificity. Any predicted probability of 0.144 or above would be classified as treatment failure, and any probability below would be a treatment success. At this cutoff, sensitivity is 0.51 and specificity is 0.65, so they're both still pretty poor. The table in the upper right shows other examples of thresholds and the resulting sensitivity and specificity of each threshold. You can see as the threshold increases, sensitivity decreases, and specificity increases. So if we think about the implications of using something like this as an actual tool, we would want to consider whether we should maximize sensitivity or specificity. If we decrease the decision threshold and we increase sensitivity, we would also increase the number of false positives. A lower threshold could ensure that we're taking more precautions to make sure people don't fail on treatment, but we would also be pouring money into intervening with patients that would have succeeded on treatment without additional support. If we increase the decision threshold and increase specificity, we would also increase the number of false negatives. This might cause providers to ignore patients that truly need additional support to achieve SVR. If these patients are incorrectly predicted to be treatment successes and we don't intervene with them, then SVR rates may not improve, and we would be wasting money potentially on ineffective treatment for these patients who need additional support in order to achieve a cure. So either way, there's a risk of wasting resources. And if an effective prediction model were eventually produced, the pros and cons of increasing or decreasing this threshold would have to be considered carefully. These are the odds ratios and confidence intervals generated by Model C, again, in the validation set. You can also see that all of the confidence intervals for the point estimates included the null value of 1 except cirrhosis. So these wide confidence intervals indicate that the odds ratios are statistically insignificant, and unfortunately, we cannot make strong inferences about the association of these variables with treatment failure. For these last couple analyses, we're actually back to the bootstrap replications from the derivation set. This figure is showing the distribution of bootstrap beta coefficients across samples in which the variable was selected. So here we're looking to see how consistent the beta coefficients are in the bootstrap samples, and this is a type of robustness check. Ideally, we want the bootstrap regression coefficients to be either all positive or all negative. If a variable was selected as a predictor in a majority of bootstrap samples, but half of the estimated coefficients were negative and half were positive, this would be an indication of model instability. This is the strength of this type of analysis because with traditional automated variable selection methods, the stability of the estimated regression coefficients cannot be easily assessed. So hepatocellular carcinoma and insurance are the only variables here that cross the null value of 0. In other words, some coefficients were negative and some were positive. For hepatocellular carcinoma, very few coefficients cross 0, so they're not of a major concern, but the beta coefficients of the insurance variable do not seem robust since they're spread relatively widely across the null value. Here, treatment history is the only variable that just barely crosses the null value of 0. And here, baseline DDIs is the only variable that crosses the null value of 0. So again, this is not very concerning because very few coefficients cross the null value. However, the generally wide distributions of the beta coefficients just further confirms that we should refrain from making strong inferences about the association of these variables with treatment failure. Okay, this is a lot, so I'm going to walk through this slow. So here I was assessing for the presence of multicollinearity by looking at pairwise combinations of candidate predictor variables. So in this table, if for any two variables the inclusion of one tended to result in the exclusion of the other, then that would be an indicator of possible multicollinearity. The second column contains the percentage of bootstrap samples in which each candidate variable was identified as an independent predictor of mortality. So we've seen these numbers before. The remaining cells contain the percentage of bootstrap samples in which the row variable was selected as a predictor and the given column variable was also selected. So I think the easiest way to look at this is to look down columns and see if there appears to be any significant drops in the percentages or if they stay relatively consistent. So the rule I used are applied. So if there's a cell that was 20 percentage points or more lower than the percent of the total models that the variable shows up in, so over here, then I highlighted it in this bright yellow color. So for example, age showed up in 89% of the models, the total models. So if there's a cell of 69% or less in the age column, then that box would be highlighted. If a variable was highlighted, then I checked to see if the corresponding pair was also highlighted, where the row and the column variables were flipped. This was not true for any of these highlighted cells. So for example, HIV and DDIs was highlighted, but DDIs and HIV was not highlighted, because 17, which is that cell, is not 20 percentage points or more or less than 28, which was the percent of models that DDIs showed up in originally. So therefore, these highlighted low frequencies may have just occurred by chance. This is also supported by the fact that the lower frequencies appeared in cases where the row variable was selected very infrequently towards the bottom of the table. The only possible exception is the combination of post-transplant and DDIs. So when looking at the corresponding pair of DDIs and post-transplant, among models where post-transplant was selected, DDIs was only selected 10% of the time, which is highlighted in the lighter yellow color. This does not follow that rule of being 20 percentage points or more or less than the percent of overall models that DDIs showed up in, which was 28, but it's close. And conceptually, it also makes sense that DDIs and post-transplant might be related, because people who have received a transplant need to be on immunosuppression agents, which we addressed before, which may increase the likelihood of DDIs. Overall, though, it doesn't seem that multicollinearity is a big issue in these models, especially since collinear variables were removed in the first variable elimination phase. Furthermore, the possible collinearity between post-transplant and DDIs is probably not important, since post-transplant was selected in almost half of the models, DDIs was selected in less than 1/3 of the models. So this means that post-transplant was included in the best performing model, which was model C, but DDIs was not. Multicollinearity is only really a significant problem if two variables tend to mutually exclude each other. Okay, so to sum things up, we were able to apply bootstrap replications and automatic stepwise regression methods to identify candidate predictor variables that are likely to be predictors of treatment failure. The best performing and most parsimonious predictive model in this case was the model that included the 9 variables that showed up in at least 40% of the bootstrap models, which are shown here. 3 variables showed up in 80% or more of the bootstrap models, namely age, hepatocellular carcinoma, and insurance, meaning these are the variables that are most likely to be predictors of HCV treatment failure. These 3 variables are supported by other studies that have found that age might impact adherence and follow-up. Older age has also been associated with an increased risk of HCV-associated liver disease that may be caused by not only a longer duration of HCV infection, but also possibly aging-related mechanisms leading to lower SVR rates. Hepatocellular carcinoma has also historically impacted results. People with hepatocellular carcinoma tend to do worse on treatment. And finally, certain insurance coverage only allows treatment of people that have more severe disease, so they're likely to do worse on treatment. Since these variables were repeatedly selected in the bootstrap models, we can have some confidence that they are predictors of treatment failure. But the final model had predictability significantly predictability better than chance in the validation set, but unfortunately, the best performing model had poor fit and poor ability to discriminate between treatment failures and treatment successes. And the model also generated statistically insignificant odds ratios in the validation set. A strength of this study is the combination of bootstrap sampling with automated variable selection. This allows us to determine the empirical distribution of a variable's likelihood of being identified as a predictor of treatment failure. And by using automatic variable selection methods alone, it's highly possible to create a final model that includes spurious variables that are not true predictors of the outcome. So our use of bootstrapping allows us to determine the strength of the evidence that a given variable is truly a predictor. One limitation was the sample size for this study, especially for a split sample. Once we split the sample, the validation set only had 416 observations and 57 events. This relatively small sample size can reduce power, increase bias and variability, and lead to statistically insignificant confidence intervals, as we saw in the tables of odds ratios generated by the final model. Another limitation of the study is that so far we have only examined main effects and did not look at any interactions, but again, this would be more effective if we had a larger sample size. We also didn't break down the individual components of treatment failure. Instead of lumping all treatment failures together, it would be interesting to look separately at those who truly did not achieve SVR, those who were lost to follow-up, and those who discontinued treatment. Again, we were limited by sample size and the information available to us in the data about patients that did not achieve a measured SVR, so it would be difficult to explore this further right now. So clinical tools for predicting probability of achieving SVR would be useful for patient and provider decision-making. The baseline characteristics that have been associated with response to therapy in the past include genotype, fibrosis, ethnicity, BMI, age, and other patient factors, but again, these were findings primarily from older regimens or from studies that only assessed associations, not predictive ability. Our study identified patient characteristics that may be significant predictors of treatment failure, but predicting response for an individual patient still remains difficult. We could build upon this analysis by adding past behavioral factors such as past adherence, interaction with the healthcare system, and utilization of healthcare resources, but we did not have these variables available in our data set since developing a predictive model was not the primary aim of the original study. This study can also be built upon by assessing on-treatment factors in addition to the baseline factors that we looked at. There's currently not an evidence-based threshold of adherence recommended to achieve SVR, but it is likely a major contributor to achieving SVR and would be an important variable to assess. With the right data available, additional analyses could try to identify predictors of poor adherence and poor patient-provider communication and subsequently assess that effect on SVR. It might also be worthwhile to look at clinic and provider characteristics in the future. This was not the aim of this analysis since we focused on patient characteristics, but a unique aspect of this study is that it included patients treated at 4 different types of clinics, including a primary care clinic. Since many patients are undiagnosed and untreated and it's relatively difficult to find HCV specialists, there's a push right now towards diagnosing and treating HCV in the primary care setting. So it'd be interesting to see if different settings are predictive of SVR. So in conclusion, the study did not result in a highly predictive model of HCV treatment failure, but it did highlight baseline patient factors that may be associated with treatment failure versus success. If this type of analysis is built upon with a bigger sample and more candidate predictors, it may be possible to develop a simple data-driven clinical tool to identify patients at risk of treatment failure as soon as the patient is referred for HCV treatment and assessed. Personalized interventions can then be put in place to help the patients achieve SVR. And ultimately, this may help to close that gap that we saw earlier between patients who initiate treatment and actually achieve SVR and help reduce the significant burden of HCV in the U.S. Thank you. Thank you. Any questions? Yeah.
So, excellent presentation.
Thank you.
Yeah, I thought you covered a lot of questions I was going to ask.
Okay.
Very good job.
Thanks.
In previous prospective clinical trials, things like HIV co-infection, HCV, genotype are very important predictors of outcome, as well as therapy and adherence.
Yeah.
These are all things that were not part of your model.
Genotype was, I don't know how easy it would be to find that slide, but yeah, genotype was in there originally. I can go back to that slide with the original candidate predictors because I went through that pretty quickly. So this was there, this is what we started with. So genotype was there, and then
may just not have had a lot of variation in genotype. But I guess it was a
Well,
factor in the end.
we had to condense it a lot too, so we had genotype 1 versus other in the end because the cell sizes were so small. So that's what we ended up looking at. And I can't remember what phase that got kicked out. If it was the second phase? Yeah, it was the second phase when we were looking at the p-values for the chi-square test, so it was greater than 0.25. Yeah.
So my question for you is, given that a lot of your predictor variables are likely proxies for something else like behavior.
Yeah.
I was wondering if there's some way to find different, or maybe through questionnaires or through other methods, find out different information on patients that
Yeah.
may be more predictive than what you might hypothesize from them.
Well,
Because
yeah.
in your theoretical framework, there were a lot of things that weren't touched on, that were part of the framework, but you didn't have data.
Yeah, we didn't have the data. And I actually, so we were just talking about this, how I have a Cerner account. The reason I have one is because we talked about going back and maybe trying to figure out past behavioral factors that would relate, but it just wouldn't have been feasible to do in the amount of time I had. Maybe in the future, because I do think that would be important. And we talked about that with Michelle Martin too, and she was thinking that their interaction with the healthcare system, how often do they come for their appointments, what's their past behavior adherence, that would have mattered. Yeah. So maybe in the future. Yeah. Yeah.
Great presentation, Nadia. Nice primer on a lot of these statistical concepts.
Thank you.
Age, the way you chose to dichotomize it is 65 and above.
Yeah.
There's a lot of overlap with Medicaid, right?
Yeah, we looked into that. There's actually not. So it was split about 50-50 between the two age groups, which was interesting. I talked to Dr. Martin about that.
That wasn't a problem.
It was not a problem.
But I was curious. One of the risk factors you said was being born between 1945 and 1965.
Yeah, so baby boomers.
Did you think about framing age in that way?
We did. Dr. Martin actually wanted to, but I didn't think that made sense because that's a risk factor for getting HCV, not for how you perform on treatment. And there's been some evidence that older patients don't do as well on treatment, so I thought it made more sense to divide it that way.
When you said insurance discriminates, it discriminates against the working employee or private insured people. Is that what you meant by discriminate? Because they had the highest level of lack insurance, if I understood it correct.
The commercially insured people.
Yeah.
Are you talking about one of the slides earlier on?
Yeah. When you said discriminate.
They had the highest rate of denial, I believe.
Right. So discriminates against people with private insurance. That's what you meant by discrimination.
When did I say discrimination?
You actually have it on your slide.
On that slide.
Yeah, go to that slide. Didn't qualify what you meant by that.
This one.
Discriminatory state Medicaid restrictions.
Oh, so there's these bans. So people, and this is different by state. But so people that, I don't know if you can read it from there, probably not. So people that have a history of alcohol or substance use or are current users in some states are not provided with, or their treatment's not covered. In some states, they have to have like stage F3 or F4 fibrosis, so they have more severe liver damage before they're allowed to get treatment. So there's different restrictions in different states.
Are you aware of any risk-sharing agreements with drug companies in which if there's treatment failure, they don't get paid for the treatment?
That's a good question. I don't know, but I'm kind of curious about that. I don't know.
It's a big thing in the industry right now, so I was just wondering if that's
Yeah.
an arrangement that
Certainly
certainly minimizes the exposure to the insurance company if they have patients. That way, all the patients could get treated, but only those who actually have their SPV level. What's the abbreviation? SPV?
SBR.
Yes.
So they have to be cured in order to have the drug cost coverage.
Yeah, seems like you thought of a lot of this stuff